Good morning, everyone. Thank you so much for joining us for our webinar today, Trauma-Informed Health Department's Community of Practice, Lessons from the 2018 Environmental Scan and Applications in Illinois. I know some people are still signing on, but we are going to go ahead and get started in the interest of time. My name is Laura Altman. I'm the director of the Illinois ACEs Response Collaborative here at Health and Medicine, and we are very excited today to have a number of speakers join us, including Brenda Bannor, Catherine Kennard, Cynthia Hall, Kate Reed, and Marlita White. So I will give everyone an introduction before they get started. So as I mentioned, I'm from Health and Medicine. We work to improve the health of all people in Illinois by promoting health equity. We are based in Chicago, but do work statewide. And Health and Medicine is the lead convener of the Illinois ACEs Response Collaborative. We are a multidisciplinary group of folks, and we work to catalyze the movement to break the intergenerational cycle of trauma and build resilience. We have mobilization efforts, collective action, and advocacy. So we have a ton of resources on our website. If you're new to our work and to the trauma, ACEs, and resilience world, we have a lot of resources for you. So at the end of the webinar, you'll get a link so you can check those out. The second half of this presentation is a panel, so we really do encourage you to submit any questions that you have for any of our speakers in the question box. We will be monitoring it throughout the webinar, so please feel free to do that. And after the webinar, you'll receive an email with a short evaluation survey, ways to participate in the collaborative, a link to all of our stuff, and a recording of the webinar. So today we are really excited. We've been working with health departments for the past year, supporting this work, and so today is kind of a culmination of a lot of that work that we've done. So we'll start with a brief overview of that work and of trauma-informed care. Then I'll hand it over to Brenda, who is going to talk about key takeaways from our recent environmental scan, and then we'll have a panel discussion at the end. So as I mentioned, with generous support from the Telegen Community Initiative and the Illinois Children's Healthcare Foundation, the Illinois ACEs Response Collaborative has been working with health departments across the state of Illinois to provide support wherever health departments are in their journey to become trauma-informed. So we started with a survey just to get a sense of the landscape here in Illinois. We've done a series of webinars, which if you haven't seen them, I encourage you to check them out. For example, one is an intro to trauma-informed care. We did another one with Ken Epstein from the San Francisco Department of Public Health, who has been leading a huge amount of work there. We have another webinar on community resilience and another one on opioids. We have a number of briefs. And we also did an environmental scan nationally, which is what we're going to talk about today, to get a sense of what health departments are doing all over the country around this work. And then lastly, we have been able to provide tailored support for a smaller number of health departments in a variety of different ways. This is an extremely brief overview of trauma-informed care, just to make sure we're all kind of rooted in the same language. But if this is new to you, I do encourage you to check out our other webinar to learn more. But when we talk about a trauma-informed organization or entity or agency, it's one that realizes the prevalence of trauma, recognizes how trauma affects all individuals involved with the program, organization, or system, including its own workforce. It responds by putting this knowledge into practice, and it resists re-traumatization of clients as well as staff. Those are the four kind of key elements from SAMHSA, and then we also add that it's organization or entity that builds resilience as well. And I just want to acknowledge that it's really a process to become trauma-informed. It takes time, and you can start with a shift in staff knowledge, perspectives, attitudes, and then you end up in a place where being trauma-informed is embedded in all your policies and practices. That's it for me. I'm going to turn it over to Brenda. We are very lucky to have Brenda join us today. She is a national expert in healthcare, among a variety of other things, and she's a longtime member of the collaborative. So she's going to talk to us a little bit about the environmental scan.
Okay, thank you so much. Just excuse my voice. I have an 18-month-old granddaughter who has been passing viruses to me, hence my raspiness. Anyhow, well, I was really thrilled to be able to do this scan. The purpose of the scan really was to just serve as a snapshot of what health departments and their partners are doing. I interviewed 14 organizations, and the organizations that I interviewed were ones really that Health and Medicine and the collaborative knew about and were familiar with. They varied. We tried to be as representative as possible also, so varying in size, geographic area, and governance structures. I said to somebody earlier, writing this report was very interesting because people are doing so many different things in so many different ways that the challenge really was to come up, or at least in my mind as I was crafting this, the challenge was coming up with common themes. But interestingly, despite the differences, a lot of common themes emerged. One other thing that I want to say is we know that there are many more health departments that are addressing trauma, and also that a 45-minute to an hour interview really only scratches the surface of what folks are doing. And so we see this really as sort of the beginning of a longer process of learning more. And one thing that I did hear from pretty much everybody that I interviewed was, wow, we really want to know what everybody else is doing. And so I think, again, that underscores the importance of really digging even deeper into this work. So what did I find? The questions that I asked first was just the journey. What started this? And so the impetus, or really the spark for all of this was different. It was for different folks. Maybe it was a really committed individual, a group of individuals, a boss that really had an incredible vision. Sometimes it was a study or a report or a workshop that folks went to. Some people, it was a community health assessment or a reaccreditation process that sort of drifted this up. So sometimes it was top down, sometimes it was bottom up. And the other thing that was interesting is where people are at. Some people chose to address this externally initially and some internally initially. And so, the external ones are really working and focusing more on community, less on really changing the culture of the health department, but more working across the community, where others were really looking at it with an internal focus. Some agencies reported balancing both internal and external work. And everybody acknowledged that, even the folks that weren't addressing it internally acknowledged that it was important to do that, but they had to figure out with limited time and energy where to put their focus first. The other thing that just really came across is that it didn't matter where the work started or how the work started, but everybody acknowledged that this just made sense, and that this was that this was really a critical way to address and change what they were doing. That things that they were doing before just didn't make sense or did not really meet the needs, and so they had to relook at this. So what I'm going to focus on today really is just the key lessons in terms of, so what were some of the common themes, the ingredients for success? And actually what I want to say here is that I did a similar environmental scan, did a similar environmental scan about 8 months ago with 27 Illinois-based organizations, not-for-profit organizations. And some of the findings that came out here were really pretty similar. And if any of you are interested in looking at that scan, that's also on the website. So what did I find? All right, one of the ingredients for success is identify internal and external champions, that champions are really critical. A lot of people said that it's important to have leadership as part of that as well, and having leadership also be part of the process. That being said, leadership isn't enough, and that you really need to have, build a base in the organization as well. And then they also said that the internal was important, but also external champions, having local government and political support. Somebody talked about the development of a separate office of violence prevention, a resolution for a county to be trauma-informed. And so these are the kinds of things, if you get external support, can really move this along as well. Recognizing that change takes time. And one thing that was said earlier is that this is a process and it's not a practice. And I think that's really what somebody said to me was, don't oversimplify it. And if it doesn't work right away, keep going, because it's not a one-time deal. You have to keep plugging away. As somebody else said, repeat, 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 and don't get frustrated with repeating. Don't try to get it all right at once. Or then if you do, you might not do anything. The next one, integrating a trauma-informed approach into existing projects, I think was really important. What people were saying is that there's so many competing priorities in organizations and a limited time to focus on new initiatives that the question is, how do you move trauma to a higher level so people really embrace this? And this goes to identifying champions and leadership as well. And what a lot of people said is, you have to figure out a way to integrate trauma into existing initiatives. And I'm just going to sort of make a quote that if this work is seen as an add-on, it will impede buy-in. We made a case that trauma-informed principles are not a standalone initiative, but rather a plate that all the initiatives could sit on. Folks also talked about health equity and social justice, and that this goes hand in hand with that. And there's, first of all, a lot of money out there for those, and also a lot of appetite for that. And so the more you can connect those together, the further leverage you can get for this initiative. And the other thing is not just looking internally to connect this, but also externally. What's happening in your state? What's happening in your community? So to try to tie that into that as well, so it's never seen as a standalone. Connecting with the community, embracing the community voice. People talked about ways that they did that. They held focus groups. They had summits, both to gain community input and raise awareness. One organization talked about how they had a grant process by which anyone in the community who was working towards building resilience could apply for a learning grant. And as they said, that was a way in which we enlisted trust-building activities to reach difficult communities who had mega trauma all the time by allowing them to have the freedom to learn and work towards finding their own solutions. And this is something that I actually heard a lot, even in the other environmental scan that I did, that people know what they need. You just need to ask and really listen to their voice. Several of the organizations talked about how they didn't get community voice before they started their work, and were very surprised after they had done a certain amount of work when they went out and actually talked to community members that the language they were using didn't resonate, and so they had to really backtrack and re-engage and really actually figure out ways to embrace the community. So they thought, what somebody said, we thought we were making a difference to find out that we weren't reaching anyone, or everyone, I should say, not anyone. Self-care, this is just, I think we all know this, really how important it is to figure out ways to have the staff take care of themselves. And the reason I put this in here is that actually some organizations had focused on this more than even the other parts of policy changes and all that they felt this would have so much leverage that they put a lot of their energy in this. Collaboration, this really speaks to the work about building and leveraging relationships. And folks talked about strong internal teams that had clear expectations, shared principles, regular meetings, that people listen to one another, practice our principles, and model the type of behavior we're hoping to achieve. One organization actually talked about how they got employee buy-in, which can be challenging, as we all know, that they actually had a mini grant opportunity of $1,000 for any staff to propose a project that would demonstrate a connection to the trauma relating guidelines and principles, and they said that really went far. There was a lot of buzz about that. People really felt invested, and they actually got some really good projects as well. There were some cautions. People said that collaboration, particularly cross-organizational or community, cross-sector collaboration, had a lot of challenges with it. And one of them is that, bringing organizations that already have been doing their own work or that have their own agendas and bringing everybody together and figuring out ways how to get a shared voice across organizations was challenging. They had to develop a groupthink mentality instead of doing individual branding and promotion. And the other thing that people said is collaboration, as great as it is, always does slow down the process, and you just have to accept that. But it really is important. Pretty much everybody I talked to talked about how important it was. Data collection, some interviewees reported promising trends. Some of the indicators people were using was number of people trained in trauma, employees who utilize the EAP programs, decreased numbers of incidents between patients and staff, attendance discipline, the use of ACE questionnaires by field nurses, and employee satisfaction. People did say, though, despite the importance on data, we really can't forget the power of a story, a picture, or an anecdote. Also, some folks said how important it is not just to talk about data, but to talk about documentation, that to really, in order to get to create an institutional knowledge, because there's so many changes in personnel, et cetera, it's important to document the process. Pursue external support and funding. I think this is really, it's not about pursuing support and external funding. What people said was that the people who had funding, people didn't say it was necessary to have funding for this, but what they said was the folks that did have external funding obviously said it provided a catalyst and a structure. And some of the grants or some of the funding and support that they talked about, SAMHSA, a lot of support through SAMHSA, the MARC grant, a lot for that. But also two folks talked about the Kresge Foundation's Emerging Leaders in Public Health and how that was really, really helpful for them for the transformation work, especially developing new leaders. Let's see, leverage and adapt existing frameworks. Just that's people talked a lot about, you don't have to reinvent the wheel. There's a lot of stuff out there and a lot of really good work out there. And some of the frameworks, the Missouri model that's being used and was developed by a group of Missouri organizations. Ken Epstein, as was discussed earlier, has some work out there, the SAMHSA guiding principles, and others. And people said that was really important to have those. Holding effective meetings, just people couldn't stress enough that even small things have helped maintain momentum, interest, and collegiality. Taking time to do a check-in at the beginning of a meeting, being flexible to change agendas, modeling the type of behavior you want to promote, and making room for emotions, which I think we oftentimes, don't embrace. Okay, and then. In terms of challenges, a lack of a dedicated position. Most people said that they didn't have one person that was doing this work. As one person said to me, "Well, I'm 1.75 right now doing this work," and so. But the folks that did have a position, especially with the cross-sector work, they said it was really important. But the other caution is you still need a team to do this work, so not to forget that. Also, what some people said is consultants are great, but sometimes when you embed it internally in your organization, it becomes uncuttable. Maintaining this is a priority. There's a lot of burnout, turnover, as one person said, the reality is that we're a small dot on a big map. We're making a big splash, but it takes a lot of effort, and it's hard to keep up with. And so it's just really, that's one of the key issues, that there's so many things happening out there. How do we make sure that this is front burner work? And also what somebody said, and I think it's really important, that it's easy to slip into an old place or get distracted when frustrated or tired. And so you really have to keep taking the temperature, and everyone's vulnerable to the next shiny thing. Change is hard, and this was particular, and this was different than what I mean, obviously change is hard for everybody, but what I heard across a lot of the interviews was, in the public sector with health departments and their partners, that this was particularly hard because they were accountable to county commissioners who are often late adapters to things, didn't understand why trauma, needed. Sometimes they didn't fit into a broader government structure. So, for example, maybe their department or their organization was willing to do this, but their HR department was part of something else, the city government, which wasn't able to do that. And so how did that trickle down? And then lack of resources for data and evaluation, and several people said it's really hard to get data points because of competed data systems, lack of evaluation experts on staff, and the reliance on people with other jobs, the 1.75 FTE, and also the prevailing desire for immediate results. And I think that's really important, and a lot of people said the rush for results could be their downfall. This takes time. Okay. And then finally, I asked people about sustainability, and people were actually very positive about this, much more positive actually than the folks that I interviewed for my other environmental scan. And several people several organizations were, well, we just changed the way we do business. This doesn't have to carry a large cost. It's about changing environments, relationships, and making decisions in different ways. So we're doing that, and so that doesn't have to take a lot of money. Others were saying that they already have it baked into their budgets, and trauma was formally embraced by government officials in the community. Now, the caveat to this is government officials do change, and so you have to continually keep informing and pushing this agenda. Other people said they've built energy and structure. It doesn't ensure sustainability, but it gives a foundation to work for. As somebody said, if it's built into the DNA of an organization, we work with our community partners, it'll be hard to stop us. There'd be peer pressure if we abandon it. The other is that the need, that part of the importance of sustainability or achieving sustainability is celebrating, promoting successes, and also evaluation. We need to move the needle to show value in the community. If no one's noticing a change, then we have a problem. Okay. Story time. I wanted to just take 1 second to talk about, and I've been trying to allude to that as I've been going through the differences between this and again, everything was the same. One of the bigger challenges in the last scan was lack of resources and funding. And again, that did not come out as, I'm not saying that people didn't say they couldn't use more money or anything like that, but that was not seen as major a barrier or as major a challenge as echoed through the other organizations. And also health departments, obviously, this makes sense, were much more involved in spearheading collaborative and interagency efforts, and so a lot of these common themes revolve more around working collectively, community voice, etc. But across all of them, the most powerful themes that resonated was the overriding commitment and passion to addressing trauma and building resistance, even with challenges. And again, what I said, a palpable interest in what's happening in other health departments, so this should be just the beginning of a longer conversation. Thank you.
Great. Thanks, Brenda. That was a lot and such a useful summary of what you found. And, excuse me, speaks also to the important role of health departments in this work. Yes, how there's just such backbone organizations and entities. So Now I'm excited to turn over to the panel discussion, and we are very lucky today to have Dr. Catherine Cunard, the Director of Health from the Village of Skokie, Cynthia Hall, the Director of Strategic Initiatives from the Winnebago County Health Department, Kate Reed, the Drug-Free Communities Project Coordinator from the ICANN Regional Office of Education, and Marlita White, the Director of Violence Prevention and Behavioral Health from Chicago Department of Public Health. And I'm not going to read all their bios in the interest of time, but they're all amazing, and we're very excited that they can be here. I'm also excited because these three health departments and then the ICANN Regional Office of Education are all at different stages in the process, so they can really speak to their different experiences. They have kind of varying areas of focus, internal versus external. Their processes started in a different way, and also we have, as I mentioned, Kate is from the Regional Office of Education, and while the health department has been a key player in that work there, she's really spearheading a lot of the work also, so it's interesting to hear that perspective. So I've asked them, the first question that we're going to talk about is just really an intro to the trauma-informed work that they're doing. So like I asked them, how long have you been doing this? Can you give a very brief overview of your activities and what's the focus of your work? I have given them the unenviable task of doing this in about 2 to 3 minutes each. So hopefully more of the information will come out as we ask further questions. So I'm going to go ahead and turn it over to Marlita from Chicago Department of Public Health. So panelists, when it's your turn to talk, if you want to go ahead and unmute yourself, that would be great. And let me know when it's time to advance your slides. So Marlita, are you there?
I am here.
Oh, great. Okay, so go ahead.
So thank you all for participating in the conversation today and for also the invitation to present on our work. In short, we've been involved with work that focuses and looks directly at trauma and, for us, exposure to violence for about 15 years now. But our dedicated team that's been focusing on trauma-focused transformation has been operating at the health department and then moving outward to other city departments for about 3 years. So since 2016. So is that, I guess that's, yeah. So we start with this focus on Healthy Chicago 2.0, which is our department's kind of social contract with the city that says that we're going to pursue aggressively health equity, and then we're looking across 9 different major areas where we have to see improvements, and one of those include being a trauma-informed city. We can advance. For us, that means we're starting and leveraging the work that the health department might be able to create and to leverage from other partners. And then our hope is that we would be able to spread that across other departments within the city infrastructure, like the Park District, our Department of Family and Support Services, our schools and police departments and so forth. But that yellow circle is important for us because, as you've heard already, the 4 R's, we're also talking about not just the people that we serve, but also the people who are employed by the city, but then those who live and call Chicago home. So that means we have to be working in partnership with other organizations and initiatives doing business in Chicago. You can go to the next slide. Within our department and our kind of steering team, we identified a number of committees, and so you see on the slide that we have a dedicated evaluation team and an assessment team, a team that we've now combined that's focusing on messaging, trying to figure out what our talking points are, what materials we might need to put out and make available for everyone, champions, a clinical focused team, policy training, and then how do we engage and understand the experience of our consumers. The next slide. So at the end of things for us, we know that the health department has lots of work to figure out how to make or either revise or refine a model that works for the health department, but simultaneously refine that work so that it is portable and can be used to support our other partners and our other city departments as they grow and develop their teams. But we know that there is existing work in the city that we need to be a part of. And so you see this conversational health and our policies that includes a recommendation that all city frontline city staff would be trauma informed. There's this work across public health departments. There's work that's existing in and across Chicago that's focused on trauma informed and resilient communities. Also work that's focused on our hospitals within the Chicago area being trauma informed. There's work that's happening already in the school system with our other statewide institutions as well. So we are really trying to, again, figure out how to do the work within the health department, how to create and loan, borrow, beg, steal, and share with other departments across the city infrastructure.
Great. Thanks, Marlita. And Kate, I'm going to turn it over to you now.
Thank you. So I think it's important to start with the why. I grew up in Nairobi, Kenya in East Africa. I moved into Pembroke Township, a community known for its trauma. And I work in an alternative school where youth are removed from their other schools for behavior and attendance issues. So every day I have the honor and the blessing of looking into the faces of those who are significantly impacted by adverse childhood experiences. So about 2 years ago, I heard Laura Porter for the first time say the words adverse childhood experiences, and not to be cliche, but it really did change my life. So I work as a drug-free communities project coordinator for a substance abuse prevention coalition that's focused on environmental strategies. And we were able to bring in Laura Porter to our community for a trauma and resiliency summit. And our whole goal with this was just to have that cross-sector collaboration. So we had about 140 different community leaders and community members, all from different sectors, all coming together to action plan about how we could become a trauma-informed community. And my favorite thing that Laura Porter did was at the end of the day, we're saying, hey, Laura, what do we do now? What are our action steps? And she really did a great job of just passing the baton back to our community and ensuring that dispersion of ownership, and really just calling each of these sectors to greatness and challenging them to steward whatever it is that they have been entrusted with, to use their resources to elevate others. And so we have really focused on keeping this a grassroots initiative as much as possible. So if you go back to the first slide, Kankakee Iroquois Cares, that is our focus. You'll see like my organization's logo is not included in that. We didn't want any others. We have many key players, but we didn't want any one logo from one of these organizations to be the one marketing this, because we want this to be truly owned by our community. And our mission is to build a trauma-informed community through raising awareness about the prevalence of trauma and the impact of adverse childhood experiences, eliminating the stigma of shame, fostering interagency collaboration, and expanding learning opportunities about trauma-informed services to build resilience in trauma. So it's for the community, owned by the community, led by the community. We've been really focusing on how can we raise up an army all across the different sectors who speak this common language. So we are now proud to say that in our little community, Kankakee, we have more theraplay instructors than anywhere else in the world. And they really focus on the science of, what do you do with a child that's come from hard places, and how can you help them heal in that moment through connected, trusted relationships with their peers and trusted adults. We also have individuals who are trained in trust-based relational intervention who can then train others. Our schools have been doing some pilot programs to study the impacts of teaching trust-based relational intervention, trauma learning overview in different doses, and then comparing that with where it's not offered, to see how our teachers then support our children when they're just needing this extra support. We're loving how our law enforcement is really getting involved with this, and they're really just moving this forward. Before, it was kind of stigmatized for law enforcement to reach out for mental health services for themselves, for their vicarious trauma, but also it was kind of like, oh, that's those people's problems. But now we're having emergency responder first aid, mental health first aid training. That's been a great success. The law enforcement, they come to our theraplay trainings and things like that. We have book studies done. We have youth and adult mental health first aid, our life education center reaches over 10,000 students every year, all the different schools with social emotional learning. And then again, ACE interface has been really integral in helping to guide our process. If you'll advance to the next slide. We're focused on really just reaching across those silos. We have to get all of our systems involved. So we've been excited to see how this has become action plans. It's been integrated in so many different systems, action plans. Our churches are doing a great job of adopting schools to provide that extra support for our teachers and to help mentor. We're exciting to see how even some of our local bars, sororities, we've had NFL football players, they're all starting to get involved. You can see we have managers of Subway and Taco John's who are allowing their staff to take time to read to the students and mentor. We have partnered with the Erickson Development Institute, and we're working on some policy memos, and everything that we do, we're really trying to get this embedded. So even a job readiness program, you may think that might not have to do with trauma, but we really believe it does. So they focus on extra things like things my daddy never taught me. So go to the next slide. Even though it has been truly a grassroots initiative, and it's really moved forward by the retired grandmother whose heart is just beating because of how she's seen this impact her own life, but then also her family members, school resource officers, just all these different individuals whose hearts are beating for this are really moving this forward. And then from there, it's led to more sustainability as different systems who have really significant impact across our communities are getting on board with this. And we've launched our ACEs Connection portal to have more of those measurables of the 11 milestones of a trauma-informed community. And we've launched Kinky United, which is specifically to look at reducing gun violence within the African American men under 25. Project Sun is really our capstone initiative with this trauma work. It's a grant that we've focused on strengthening and unifying our networks to really ensure that we have more systems alignment to support our families holistically. So we're excited to see the future of how we grow even more to become a trauma-informed community. Thank you.
Great, thanks so much. And Dr. Cunard?
Hi, good morning. I'm Dr. Catherine Cunard, a public health and preventive medicine physician, and I have been the director of the Village of Skokie Health Department for 10 years. We're very early in the journey to become a resilient community, and I'm sure pleased to be with you this morning to share what we've accomplished thus far and learn from all of you to inform how we proceed from this point forward. Thank you. Skokie is located just north of Chicago and at 10 square miles with a population of 65,000 is about the size of a Chicago ward. The population is very diverse with 42% being foreign-born and more than 100 languages and dialects spoken. The largest foreign-born populations are from the Philippines, South Asia, and Assyrian refugees from Iraq and Syria. The community is served, if you could go to the next slide, by our state-certified health department with 17 employees. Oh, thank you. Okay. Surprisingly, I became aware of adverse childhood experiences in 2016 when I read J.D. Vance's book, Hillbilly Elegy. Considering that I was initially trained as a family physician and that I have a Master of Public Health, I was stunned that I had never heard about ACEs before. It happened that at the time we were engaged in a two-year community health needs assessment involving the Board of Health and the I-Plan Committee, if you could go to the next slide, to create the 2017 Skokie Community Health Plan, which is a 5-year blueprint for the health department and our numerous community partners. I learned the work that the Cook County Health System Pediatrics Department was doing to address ACEs in Chicago and invited Dr. Stan Sonu, who is spearheading that effort, to speak to the Skokie Board of Health. Our chair, Dr. Michael Drackler, who is an obstetrician, was equally shocked that he had never heard of ACEs and immediately arranged for Dr. Sonu to speak to the pediatricians, obstetricians, and family physicians at our local hospital system, which is North Shore University Health System, a 4-hospital system. We also provided educational sessions on ACEs for the I-Plan Committee, which is comprised of representatives from various community entities such as the hospital, public library, park district, schools, and community health. The end result, if you could go to the next slide, was that numerous initiatives to help Skokie become a trauma-informed community were included in the 2017 Community Health Plan. This plan was presented to the Skokie Board of Trustees and approved in July 2017. It has also been approved by the Illinois Department of Public Health. A dedicated core community group has come together to work on this daunting enterprise, and our first two steps were to attend the September Healing Trauma Healthy Communities Conference in Milwaukee so we could learn together, and to invite representatives from the Illinois ACEs Response Collaborative to speak at Skokie Village Hall as a local kickoff event. 40 people attended that discussion, and we realized there's considerable interest in the community. In November, our group held a Resilient Families event at the Skokie Public Library, and 100 families participated. We had a wonderful speaker, Dr. Joanna Lewis, who heads up the pediatrics residency for the Advocate Health System. We provided dinner and breakout sessions, including mindfulness, yoga, fair play, as was just mentioned, and a deeper dive into ACEs. I realized that we had created a safe space for people when the first question was from someone who wanted to know how to speak to her children about a family member's suicide, and a grandmother raising 3 grandchildren who spoke from her heart about the challenges she is facing. Dr. Lewis responded compassionately with words of encouragement, and the audience spontaneously broke into applause for the grandmother, which was certainly a very powerful moment. Last slide, please. Wrapping up my comments, this week our group met and discussed this slide from the Los Angeles Unified School District, which inspired us to move from focusing on ACEs and trauma to healing. Honestly, we feel as if we've gotten on a speeding train. We started just hearing about ACEs, and now we're suddenly moving to the idea of healing. We have, at least for now, settled on calling our group the Skokie Resilient Community Collaborative, and our next step will be providing education and training within our organizations, including physicians within the North Shore Health System and for the public. Thank you, and I look forward to our conversation today.
Okay, thanks so much. And now on to Cynthia from Winnebago.
Thank you for letting us highlight a little bit of our work here with the trauma-informed community. In our most recent community health assessment and improvement plan, 3 key priorities were identified for our community, and those were maternal and child health, mental health, and violence. And as the health department put together work groups to address these priorities, we discovered that a common theme emerged, and that theme was trauma. So our violence reduction work group reached out to key community stakeholders to start the discussion about how trauma-informed care can interrupt the impact of trauma. And to address this, we held a summit in March, and we had about 150 people attend. Raul Almazar from SAMHSA was the consultant and did the presentation for us. And as a result of this summit, work groups were formed to sort of address trauma on a different level. And on the next slide, you'll see the work groups that we have. So we have a collective impact work group, and one of the co-leads of that group is our Rockford Health Council, and they've just developed a proclamation to take to our cities and municipalities to proclaim us as a trauma-informed community, or at least to identify that we're working toward becoming that. We have an education work group that's working with the regional superintendent of schools, and they just recently hosted a social emotional summit where they did a poverty simulation. With our employment work group, we're trying to work with the Chamber of Commerce to show business community why trauma-informed is important to them. One of our lead groups so far has been our film series. We've worked with the Rockford Public Library to show 6 films that are trauma-related. Each one's followed by a panel discussion. We thought that in the series we would touch about 125 people, and we were astonished to have over 1,200 attendees at that event. And they've now since started a book club that will begin in January to sort of keep that momentum. We have a Handle with Care work group that's been fully implemented in the Harlem School District. And another co-lead is the Office of Domestic Violence and Human Trafficking. They're working with Rockford Public Schools to get them engaged. The idea here is if a child's been involved in some sort of trauma that involved the legal system, so maybe they witnessed a shooting or their parent was arrested, the law enforcement agency would contact the school just to let them know to handle with care. So they don't describe any of the situation, but they just want the teachers and the staff at the schools to realize that there was some trauma related to that child and they may need to be sort of handled with care. We have a healthcare provider work group with the University of Illinois College of Medicine at Rockford and Rockford University. And they want to work with our healthcare providers to help them identify trauma and deal with that in their patients. We're working with the Department of Human Services on a historical transgenerational work group. Judge Janet Holgram is our lead on the judicial practices work group. They're training all of our judicial system on trauma-informed care. We've worked with V2 Marketing to help us get these pieces together, and you'll see in our logo we also don't have our health department name, as we really tried to make this a community initiative. And then we have a training work group made up of Youth Services Network, Children's Home and Aid, and Early Learning Council, and they've already presented to over 1,000 attendees. So we're really happy with where we're at, and we know we have so much more to do.
Okay, well, thank you, everyone. And I think we covered actually a lot of some of the questions that I was going to ask got covered in the presentation. So I am going to skip through, and in the interest of time, skip through the first couple questions. But I just want to acknowledge it's so great to hear just the variety of ways, not only that of the activities that are being done, but the ways that these this all launched in the different health departments. I think there are some common themes that showed up, but also just some different ways that people are doing this together. So thank you all for that information. So I'm going to skip this buy-in question because I think some of this was kind of covered in the presentations. And Kate, if I know that you've talked about having like a really grassroots approach to this. Could you just briefly talk a little bit more about the role of community members and that are in your trauma-informed transformation process? And Kate, are you still on? Oh, yeah. Okay, great. Go ahead. Yep.
Yes. So there's a Chinese proverb that says it well. It says, "Go to the people, live with them, learn from them, love them. Start with what they know, build what they have. But with the best leaders, when the work is done, the task is accomplished, the people will say, we have done this ourselves." And so that really is our heartbeat, to elevate our community leaders and to find who has not yet been reached, and then how can they be equipped to become a champion, to steward their sphere of influence and impact them best. So trauma-informed individuals are great, organizations that are trauma-informed better, systems that are trauma-informed the best, but we will never have a trauma-informed community until we get out of our silos, our comfort zones, and really just elevate those with lived trauma experience to guide this process and use their voice. So we have been really intentional with that. I absolutely agree with what was said earlier, that definitely slows the process down in significant ways, but it's worth it because that is where it's far more sustainable and more impactful. So I mentioned earlier, some of our coalitions have now made the decision that they will not expand their steering committees with any more organizations, though there's so many more people who want to be a part of this trauma-informed work. They will not expand them unless they bring first a youth or a parent who have come from significant trauma to the table. So we're really focusing on which communities' voices are usually neglected, and then how can we really use them as leaders. And then again, every different group that's involved with this, they have their own people, their own language. So how can we go to all those different languages and those different values and help them to collaborate? So for example, we had 2 retired grandmas who organized a town hall meeting. Representatives from the governor's office came to. So it was just 2 grandmas. They didn't have connections to organizations, but they just made it happen. So we think that's really important for this to be sustainable, is for everyone to use their unique sphere of influence to really move this work forward.
And that's a perfect segue. Thank you, because that's a perfect segue to our next question, which has to do with maintaining momentum and planning for sustainability. And so, Kate, you really spoke to I mean, one of the things that Brenda found in Environmental Scan is how important it is to have community members involved. Cynthia, can you talk briefly about how you have so many different work groups? So how do you maintain momentum among all those work groups? Like, even just give kind of some of the nitty-gritty things that you all are doing to keep those groups moving forward and thinking about the long-term sustainability.
That's actually perfect timing for my question. We do have a lot of work groups. We've actually added a couple of work groups since we started. Some of them have their kind of own internal momentum, like the film series. They saw success from their efforts, and that just sort of motivated them to continue. So they're going on with a book series. They need very little from us to sort of keep their group moving. The training work group trained 1,000 people. So rather than getting motivated by their success, they're feeling overwhelmed by it. So they know that they need to kind of increase their bench strength, and they're now doing a training of the trainers because they realize that their small group alone cannot take away from all their other job responsibilities that aren't trauma-informed care to provide these trainings for us. But as an agency, we realize we have a lot of work groups out there, and that's a lot to manage. So we actually applied for and received an AmeriCorps member. So she's going to be with us for 11 months, and she's really tasked with serving as a liaison amongst these groups so that the groups know what each other is working on, and then they can sort of build and collaborate off of that. So we're excited to have her, and we're also constantly seeking funding. And one of the other things that we're doing to sort of build the sustainability of this is, in addition to seeking funding from, for example, our local community foundation, we've also asked them to integrate trauma-informed care principles into their funding applications. So if someone's coming to seek funding from them, they'll be asking them, is your agency trauma informed? So hopefully that will keep us busy in training and getting others within our community involved in trauma.
That's so interesting, how all those different ways that you're kind of like baking in the momentum and the sustainability in that multi-pronged approach, I think is really a smart way to do it. And we did get a question. Can you briefly tell us do you know which films were part of the film series that you all had? I think you did Paper Tigers and Resilience. Is that right? Cynthia? Maybe we lost her. So we'll follow. There was a question from the audience about that, so we will follow up with that answer. And then I think we probably only have time. We might only have time for one more question. So I want to make sure that we talk about data and evaluation. And I know that Marlita at Chicago Department of Public Health has really captured a ton of different types of data. So Marlita, I was wondering if you can talk about not only like your evaluation plan, but some of the things that you've already done, like your staff survey and your built environment scan as well. I know Marlita was having some technical difficulties, so let's see if this works. Marlita, are you there?
Sure. Can you hear me?
Oh, yeah, great. Perfect.
Okay. So one of the things, well, I guess I'll start with, as you alluded to, we do have a multi-leveled assessment process. So we have an all-staff assessment that talks about kind of knowledge and skills and attitudes. Then we have multiple ways where we're trying to get a better sense of our consumer experience. And those assessments live within those 9 different clinical pathways. Then we have we did an assessment of our human resource kind of snapshot of how we're hiring, how quickly people are leaving. We looked at our levels of complaints and grievances, all the way to federal grievances. We have done a policy scan looking across our various policies, and now we're developing a tool that will be used as a part of kind of onboarding new policies to ensure that it's trauma informed. We did do an assessment where we did walkthroughs in 16 of our facilities to try to determine whether we had kind of infrastructure issues and where those pain points might reside. And then across our clinical teams, those 9 streams that I mentioned, we engaged both in kind of top level managerial assessment of where we had pain points, and then we did a confirming round of staff focused discussions also in our clinical space to really figure out where we could identify opportunities to embed improvements and where we really needed to focus our energy immediately. And so that creates a lot of data. And what we've been very interested in is how to make sure that all the data that we're collecting has a use, and that we're planning on how we're going to actually make that data talk back to us and guide how we are developing forward. So we do have an evaluation team where we have epidemiologists that are sitting on that team and really managing and moving forward. We have a logic model that helps us ensure that we're asking questions that will matter. And then we have this process, and it is an iterative process where we identify all of our data kind of in a database environment, all of the data, then we figure out based on that data what kind of red light and green light, where our red lights are. These are things that we really need to act upon. And then we go through a multi-level process of figuring out the 9,000 things, for example, that people say, oh, we really need to fix this. How much of that, of those items that need to be fixed are trauma informed and directly related to trauma? How long will it take to see improvements? How expensive in terms of affordability? And will these improvements actually matter for the people who have raised those concerns? And so that's our process of trying to figure out how to get data and then move that data and have that data drive improvements.
That's really incredible to have so many different layers of the data. And I think one thing to point out too about how Chicago Department of Public Health is doing this is you're really starting with a focus on internal. I mean, I know you talked about this, but just to reiterate that you're doing all this work internally in your department first before you trained all of your staff first before looking at your sister agencies. For example, you looked at all of your own built environment. So you're really, I know here in Chicago, you're really leading by example with what you're doing internally, which is great. So we're almost out of time, and Dr. Cunard, I just wanted to give you, we had to skip one of the questions, so I wanted to give you a chance if there's anything else that you wanted to add to any of these questions. I know you're earlier on in the process, but I think a lot of what you've done to involve community members, for example, is really great. So is there anything that this has prompted you to want to add?
No, I did have a question, just a question about how the police were involved, persuaded to participate in TheraPlay. I thought that was interesting. We do want to work with our police department, and our initial discussion with our police chief did get kind of a rolled eye. So we know we have some work there. So I just would have a question for other panel member. How did you approach the police? In what way to persuade them to participate in something like TheraPlay? We had been talking about maybe just having a few minutes of mindfulness meditation or something before each shift or whatever, but as I said, got met with a bit of an eye roll. So any thoughts?
Absolutely. Well, it's all about relationships. And so I think that's why it's so important to have your champions within the sectors who do speak their language and have already earned their respect and everything. And if they can be the ones presenting it to the other law enforcement, that's what we've had to be more successful. But again, it starts with that top leadership and getting their buy-in. So after our first Trauma and Resiliency Summit, the mayor and the chief of police of this one municipality, they said, police, if there's any trauma-related trainings, we want to be at all of them, because they just saw the impact that it had. And then from there, when we started doing the mental health first aid, we wanted it to be taught and led also by law enforcement officers. They have an emergency responder track. So all of our law enforcement are getting trained in this mental health first aid, and that has created more room and interest for them to want to be engaged in things that are a little more unique, like laying on the floor with kids to play games and TheraPlay and things like that.
Yeah, if I can, this is Brenda. One thing to add is when I was interviewing people, both for this scan and for the other one, is that crafting your message for your specific audience is really important. So the things that are going to resonate with law enforcement, I mean, they might roll their eyes. When you mentioned mindfulness, that's not something that's going to resonate with them. And so what is it how can you craft your message in a way that they see it as a win for them as well? And I think that's really important, and to start with them in a place that really hits them where they you know, where it resonates. So.
Okay, so I want to be
respectful. Sorry, I just wanted to add one other thing. This is Dr. Kennard again. Our fire chief was completely on board and already was thinking along these lines. So it just depends on the person, I think, too.
Absolutely. Yeah.
This is so interesting, and so we want to, the Illinois ACEs Response Collaborative, we want to continue in planning and continuing to work with health departments, and we're hoping to this be the beginning of a number of kind of calls or webinars like this that are interactive, and this is giving me we're going to be reaching out to ask for things that different health departments would want to talk about, but it is making me think that maybe we should do one that focuses on partnerships with a variety of stakeholders in our communities, or that might be one of the topics. So stay tuned for more information about that. Also, of course, please feel free to reach out to me. My email address is on the screen, or to Brenda if you have any questions. That was just put that on its own. Check out our website for resources. Also, if you have specific questions for your health department, we are happy to help and provide support in any way. So please don't hesitate to reach out. We can always connect you to someone else if they're better suited to support you. And then I also want to say really thank you so much to Brenda and our 4 panelists for your time and your input. It's so helpful to be able just to share and learn from each other, and you all are doing such amazing work. And there's so much work happening across our whole state, so it's really great to be able to get everyone together. So please don't hesitate to reach out with questions, and I, again, thank you so much to everyone who participated today. So have a great day.
Thank you.